We live in an era that is uh, basically defined by a constant, almost overwhelming stream of statistics.
Yeah, overwhelming is definitely the right word for it.
Right. I mean, you scroll through any news feed or read a policy briefing, and you are immediately met with these massive, sweeping numbers about global health.
Absolutely.
We constantly hear, that global life expectancy is trending up, or that the prevalence of a specific disease has dropped by a certain percentage.
Right, the big macroeconomic style averages.
Exactly. But when we look at those averages, there's this crucial question that kind of goes unasked.
Which is, who is hiding inside the margins of error?
Yes. When a global or a national average paints this rosy picture of progress, who is actually slipping through the cracks?
And that right there is really the defining challenge of modern epidemiology and public health in general, honestly.
And the zoom level is just too far out.
Precisely. When you zoom out far enough, an average is highly effective at smoothing over localized crises. A national statistic doesn't tell you if a specific community, say, a community marginalized by geography or economic status or a disability, it doesn't tell you if they're experiencing a completely different reality from their neighbors just a few miles away.
Which is terrifying when you think about how funding is allocated.
It really is. The broader the data, the easier it is for severe inequalities to remain completely invisible to the people actually making those policy decisions.
Well, that brings us right into the source material for today's deep dive. We are looking at an official departmental update straight from the World Health Organization.
Released quite recently.
Yep, March 3, 2026. And this update details a massive overhaul to two foundational global health tools.
The Health Inequality Data Repository.
Right, known as the HIDR.
Yeah.
And the Health Equity Assessment Toolkit, or HEAT.
Two very big acronyms with very big implications.
Exactly. And our mission today is to examine the architecture of these updated tools. We want to understand how they manage just an unprecedented volume of global data.
And crucially, how this data is actually deployed to change health outcomes on the ground.
Right, because you don't need to be a data scientist to grasp why this matters. We're going to translate these massive databases into the real-world impact they have on human lives.
So to really understand the implications of this WHO update, we have to start with the sheer scale of the repository itself.
The HIDR.
Right. The newly updated HIDR is now officially the largest public repository of health inequality data in the world.
Which is saying something.
It is. With this 2026 update, it boasts over 13 million individual data points.
Oh.
And those points capture more than 2,400 distinct health indicators.
Let's just pause on that number for a second. 2,400 indicators. That is a staggering level of tracking.
It's granular in a way we haven't seen before.
Right, because we aren't just talking about basic mortality rates or the prevalence of major diseases like malaria or TB.
No, not at all.
We are looking at incredibly specific metrics, like everything from the percentage of a population with access to specific sanitation facilities.
Vaccination rates for highly specific demographic cohorts.
Exactly. Or maternal care access in deeply rural areas. It's huge.
Yeah.
But looking at the source material, the thing that really stands out to me is the logistics of how this vault was actually built.
The aggregation.
Yeah, because the WHO didn't just generate 13 million data points in a vacuum, right?
Right. The HIDR is fundamentally an aggregation project. The repository currently contains 62 massive data sets pooled from a really vast network of global organizations.
It's a who's who of global data.
It really is. You have contributions from the World Bank, UNICEF, the Demographic and Health Survey Program.
Which is the DHS.
Right, and Eurostat. And then you add in data flowing from the Global Data Lab, the OECD, the UN Interagency Group for Child Mortality Estimation, UNAIDS.
And the Institute for Health Metrics and Evaluation, the IHME.
Exactly. It is a massive collaborative architecture.
But wait, let me push back on that a bit.
Sure.
If the WHO is pulling from 62 different data sets, and these are managed by entirely different global entities, how do they ensure that data is actually comparable?
That's the big question.
Because if, say, UNICEF defines a specific health metric slightly differently than the OECD, or if Eurostat collects data using a different methodology than the DHS, aren't they risking mixing apples and oranges?
It's a very valid concern.
Like, how is this repository not just a massive tangled mess of incompatible data?
And that is exactly why this update is such a monumental achievement. It all comes down to the rigorous process of data harmonization.
Harmonization.
Right. Before any of these 13 million data points make it into the HIDR, they have to be standardized.
So they're translating everything into a common language, basically.
Exactly. The WHO data scientists have to align the definitions, they have to adjust for methodological differences in how the surveys were originally conducted.
Which I imagine is incredibly tedious.
Extremely. They have to ensure that a metric representing, let's say, maternal mortality from a data set in sub-Saharan Africa is statistically comparable to one collected in Southeast Asia.
So it requires a phenomenal amount of epidemiological and statistical heavy lifting on the back end.
It's a huge undertaking.
And there is a fascinating caveat noted in the WHO departmental update regarding this exact process.
The official statistics note.
Yes. Because they are pulling from so many external published sources to achieve this comprehensive view, they explicitly state that not all of the datasets represent official WHO statistics.
Right.
That feels like a really significant philosophical shift for an organization like the World Health Organization.
It is a massive shift. Historically, large intergovernmental organizations can be, well, very protective of their own data ecosystem.
And territorial, even.
Exactly. By explicitly including non-official WHO statistics, they are essentially prioritizing the mission over institutional ownership.
Which is rare.
Very rare. They are acknowledging that to get the clearest, most accurate picture of global health inequality, they have to rely on the expertise and the legwork of a diverse array of respected sources.
It's a highly pragmatic approach.
It is. They are basically saying, we don't care who collected it, as long as the methodology is sound and it helps us see the full picture.
Here's where it gets really interesting, though. Volume and harmonization are impressive. But what actually gives this repository its teeth is the resolution.
The detail.
Right. Having 13 million data points is only useful if you can slice that data in meaningful ways. And this is where the concept of disaggregated data becomes the true engine of the HIDR.
Disaggregation is the antidote to that deceptive national average we were talking about earlier.
Break that down a bit more.
Sure. When you disaggregate data, you are breaking it apart into smaller, highly specific categories. The HIDR doesn't just track health indicators overall. It tracks them across 22 different dimensions of inequality.
22 dimensions. And when you look at those, you realize just how granular this gets.
Yeah, it goes way beyond the basics.
Right. Tracking data by age and sex is standard practice. But the HIDR allows researchers to cut the data by disability status, migratory status, education level,
Economic status.
economic status, employment status, and incredibly specific subnational regions.
Which is huge.
Let's explore the complexity of that. Tracking health outcomes by migratory status, for instance. That seems incredibly difficult from a logistical standpoint.
Oh, it is notoriously difficult. Migratory populations are often transient. They frequently fall outside of formal registration systems.
Right. They might not have a permanent address to send a survey to.
Exactly. And in many cases, they may actively avoid interacting with official government health systems due to legal concerns, or simply a lack of linguistic access.
So they don't even show up in the clinic data.
Right. Consequently, they are usually the first group to be completely excluded from standard national health surveys.
So by establishing migratory status as one of the 22 core dimensions in the HIDR,
The WHO is forcing the global health community to figure out how to capture this data. They are forcing us to bring these populations out of the statistical shadows.
the same applies to tracking data by disability status, I imagine.
Absolutely.
We often look at healthcare access as a monolith.
Yeah.
But if you can cross-reference physical or cognitive disability status with, say, preventative care access, you might reveal massive systemic failures that are just completely invisible to the broader public.
Exactly. Let's imagine a highly plausible scenario to illustrate why this level of disaggregation is so vital.
Okay, lay it out.
Imagine a middle-income country that has just released an annual public health report, and they are celebrating a significant, sustained decline in maternal mortality rates.
Great news on the surface.
Right. On paper, the national average looks fantastic. The health minister is taking a victory lap, and international donors are looking to redirect their funding to other pressing issues.
Because they're assuming the maternal health crisis in that country has been solved.
Precisely. Because the top-line number says mission accomplished.
Right.
But then an independent researcher takes that exact same country's data and runs it through the HIDR.
Then they slice it up.
Right. They disaggregate the maternal mortality indicator by two intersecting dimensions, let's say economic status and subnational region.
Okay.
Suddenly, a completely different reality emerges. The researcher discovers that while the national average has indeed plummeted, there is a specific, remote, largely agricultural province where the maternal mortality rate for the lowest income quintile hasn't improved in a decade.
So the national average was being artificially buoyed by rapid improvements in urban, wealthier centers,
Exactly.
completely masking a stagnant, localized crisis.
And that is the true power of disaggregated data. It prevents premature victory laps.
That's a great way to put it.
It allows policymakers to see that the job isn't done, and it provides the irrefutable evidence needed to redirect funding specifically to that agricultural province.
It turns an invisible tragedy into actionable data.
Exactly.
But that brings us to a critical operational challenge. We have this vault. We have 13 million data points, meticulously harmonized, categorized across 22 dimensions.
A lot of numbers.
A sea of numbers. But raw data in a vacuum is practically useless to a local policymaker or a regional health advocate.
Most people don't read raw data.
Right. Most people working on the ground to improve community health do not have the time or the statistical training to manually parse through endless spreadsheets.
Definitely not.
So we have 13 million data points, but what do we actually do with them? How do people extract a narrative from that ocean of numbers?
And that is where the second half of this WHO update comes into play, the Health Equity Assessment Toolkit.
Heat.
Yes, HEAT. And specifically, the release of version 7. If the HiDR is the engine, HEAT is the dashboard that allows users to actually navigate and interpret the data.
To get some context for you listening, the HEAT software has been evolving for a while now.
It has.
The WHO originally launched it back in 2016 as a standalone tool to analyze built-in data. Then, a really crucial pivot happened in 2017 with the introduction of HEAT Plus.
The plus is key.
Yeah, the Plus allowed users to upload their own custom data sets to be analyzed alongside the global data.
Which opened a lot of doors.
And now, with this March 2026 update, version 7 is fully preloaded with the entire 2025 HIDR data update.
The true value of HEAT version 7 lies in its ability to visualize the gaps. We were just talking about how difficult it is to convey the urgency of a localized crisis using only raw numbers.
Right.
HEAT takes that dense, disaggregated data and translates it into interactive graphs, maps, and comparative tables.
Which fundamentally changes how health advocacy works on the ground.
Completely.
If you are a local health official and you're trying to secure funding for a new rural clinic, handing a finance minister a 50-page spreadsheet of mortality rates is rarely going to be effective.
Their eyes will glaze over immediately.
Exactly. But if you can project an interactive, color-coded map generated by HEAT,
A map that instantly visually proves that a specific district is in the red compared to the rest of the country.
the conversation shifts immediately. It makes the abstract tangible.
It essentially democratizes high-level epidemiological analysis.
That's a great point.
Visualization is essential. But if we really want to understand the massive leap forward with version 7, we have to look at the brand new feature they've introduced called the determinants component.
Yes. This is where the tool shifts from simply tracking what is happening to analyzing why it's happening.
The determinants component is truly fascinating. Up until now, we've mostly been discussing health indicators, the actual outcomes, like who is getting sick, who has access to vaccines, what the mortality rates are.
End results.
Right. But the determinants component allows users to generate scatter plots that reveal the direct statistical associations between those health indicators and the root determinants of health across different regions.
So it forces a structural perspective.
It does. The WHO operational framework uses 6 specific domains of health determinants to build these scatter plots.
Let's list those.
Sure. They are economic security and equality, education, physical environment, social and community context, health behaviors, and healthcare.
And it's crucial to understand that these aren't just isolated categories.
Not at all. They are interacting forces that make up the foundational blocks of society. You have the expected clinical side, but HEAT forces you to cross-reference those outcomes with structural, everyday realities.
Let's unpack how these domains actually interact in the real world, because it paints a very complex picture of public health.
It does. Let's look at how the physical environment interacts with economic security.
Okay.
The physical environment domain covers everything from access to clean drinking water to the levels of industrial air pollution in a given neighborhood.
Right.
But your exposure to those environmental factors is almost always dictated by economic security.
Because housing costs dictate where you can afford to live.
Exactly. A scatter plot in HEAT version 7 might vividly illustrate how severe wealth disparity in a specific region directly correlates to increased respiratory diseases,
Mm.
simply because the lowest income quintiles are zoned into areas with poorer air quality.
You see similar intersecting effects when you look at the education domains. We know that maternal education levels are consistently one of the strongest predictors of long-term family health.
It's a massive factor.
Education directly impacts the health behaviors domain, things like dietary choices, tobacco use, and navigating preventative care.
Right.
So a researcher using HEAT can plot local education funding against localized child mortality rates to clearly demonstrate that building a school can be just as critical a public health intervention as building a hospital.
And we cannot overlook the social and community context domain. This deals with the actual social fabric of a region. It measures community support, social cohesion, and the systemic impacts of discrimination or social isolation.
How does that look on a scatter plot?
Well, when you cross-reference social context with health outcomes, you often find that strong community networks act as a massive protective buffer against disease,
Interesting.
while marginalized groups suffering from systemic discrimination experience chronic stress that manifests in highly tangible physical health disparities.
And before this determinants component existed in version 7, investigating those correlations was incredibly labor-intensive.
It could take months, years even.
Right. If an independent researcher suspected that a localized spike in a metabolic disease was linked to a combination of poor physical environment, like a lack of green spaces, and low economic security, they would have to manually pull the clinical disease data from one agency.
Then source the environmental data from a municipal planning board.
Find the economic data from a census bureau.
And try to construct a statistical model from scratch.
It was a huge barrier to entry that prevented a lot of vital research from ever getting off the ground.
But now you can instantly generate a scatter plot mapping those exact variables.
Yeah.
The software manages the heavy statistical lifting.
Which frees up the researchers, the sociologists, and the policymakers to focus on designing the actual interventions.
Which brings us to the ultimate question of systemic impact. Why does this deeply technical data crunching and software updating actually matter for the future of global health?
Right. What's the big picture here?
To ground this, let's look at a quote directly from the source material. Ahmad Reza Hossainpour, the team lead for health inequality monitoring at the WHO, stated something really profound.
Okay, let's hear it.
He said, providing easy access to the latest global inequality data through the repository and maintaining tools like HEAT to promote the use of these data are important components of our work on health inequality monitoring. Together, the Health Inequality Data Repository and HEAT pave the way for users and countries to better understand where inequalities exist and start to determine how they can be sustainably addressed.
Sustainably addressed. That phrase right there is the crux of the entire endeavor.
It really is. Health inequality monitoring is completely useless if it is treated merely as an academic exercise.
Right. Publishing a paper that confirms marginalized people suffer worse health outcomes doesn't actually help those marginalized people.
No, it doesn't. The entire architecture of the HIDR and HEAT is designed to force action. It is designed to find out exactly who is being left behind, provide undeniable statistical proof of that reality, and use that evidence to mandate changes in clinical practices and funding allocations.
So going back to our earlier example, if the disaggregated data clearly shows that a specific rural migratory population has a vaccination rate that is 60% lower than the surrounding resident population.
The response isn't just to publish a chart.
Exactly. The response is to use that exact data visualization to bypass bureaucratic hesitation and immediately secure targeted funding for mobile vaccination units that specifically serve that transient community.
The data dictates the exact shape of the solution.
And furthermore, this initiative is structurally embedded into the highest levels of global health strategy.
Yes. The WHO update explicitly ties these tools to their general program of work, specifically GPW14.
Right, so this isn't just a side project.
No, health equity is the central organizing principle that guides the organization's overarching funding and operational focus for the coming years. By overhauling the 8IDR and HEAT, they're essentially providing the technical scaffolding required to achieve the philosophical goals they've set out in GPW14.
Because you simply cannot achieve health equity if you do not have the tools to accurately measure health inequality.
Exactly.
So taking a step back, we are really looking at a profound evolution in how we understand global health.
They really are.
We have moved from a sea of disconnected generalized statistics to a centralized vault of 13 million harmonized data points. We can cut that data across 22 complex dimensions of human life.
And we have an interface in Heat version 7 that allows anyone to visually map the root causes of disease and disparity.
It is a phenomenal achievement in global coordination. But the most exciting aspect is how these global tools can be applied locally.
Right, remember that Heat Plus allows users to upload their own custom datasets.
Which is so empowering.
It means that an independent researcher at a small university or a local city council member or a regional health advocate now has access to the exact same analytical power as a WHO epidemiologist.
Which leaves us with a provocative thought to end on.
Go for it.
We've spent this deep dive looking at how these tools uncover inequalities on a global scale. But now that this technology is fully democratized and freely available, what happens when people start using it on a micro level?
That's a fascinating thought.
If you had the ability to gather the health, economic, and environmental data of your own specific city or your own neighborhood and plug it into Heat, plus, what hidden disparities do you think you might find?
Right. What invisible dividing lines right in your own backyard might finally be brought to light?
It is a question that challenges all of us to look closer at our own communities.
And it underscores why data, when properly organized and visualized, is one of the most powerful tools for social change.
It truly is. Well, thank you for joining us for this deep dive. As you continue to navigate the news and the constant barrage of statistics, keep questioning the numbers, always look for the people hidden inside the averages, and we will catch you on the next deep dive.